some background. So we're going to talk to you today about tube weaning. But before we get started on that, just wanted to tell you a little bit about this session, because this is actually our first kind of topic-related community of practice for the province, which is really exciting. You may have seen this come out to you. The invite was updated with some further information, but really this is for everybody. This, despite coming from ACH, this project, and there's a little bit of a presentation first, we're really jumping into discussion in breakout rooms. And it's actually just such a great opportunity for us to join in, speak up, ask questions. So please do comment, whether you're happy writing that in the box or just unmuting yourself. We really want that connection and collaboration. If you can, please have your cameras on, but specifically and particularly once you go into the breakout rooms, because it's so much nicer to see each other's faces. And really throughout this, although, like I say, this is coming from a tertiary site, an eating, feeding, swallowing program, it really is about reflection on your own practice and your programs and how this might relate to you, because we all see these children just across the continuum. And then healthy debate is very much encouraged, but have an open mind and recognize that we come from different lenses. And so, our practices may look slightly different, and that's the kind of richness of our tapestry of feeding across Alberta. So, firstly and importantly, our work takes place on the historical and contemporary Indigenous lands, including the territories of Treaty 6, Treaty 7, and Treaty 8, and the homeland of the Métis Nation of Alberta, and 8 Métis settlements. We acknowledge the many Indigenous communities that have been forged in urban centres across Alberta. So, our project, what was it? So, at Children's Hospital, we launched a pilot project to support tube weaning. This came out from the top, one of the top priorities of parents from our PEAS collaborative. And it had been an ongoing goal within our own teams here, but we certainly know that that's also true across many teams and across the province and for many families. So we've developed this pilot project, and the goal was to wean G-tube and NG-tube children using a defined care pathway. So taking a more standardized approach, but recognizing that this work was already happening. And our project team for this was interdisciplinary, so dietitians, speech language pathologists, occupational therapists, peer mentors, physician quarterback, clinical leaders, and managers were involved. So what is tube weaning? So it's a process of decreasing the enteral feeds of a child who is tube fed, either NG or G tube fed, and increasing their oral intake over time.
So before we started the pilot, we looked at a variety of research. So looked at 12 different studies that had 725 patients total. We reviewed the models for weaning children off of enteral nutrition, which was a rapid evidence report put out by PEAS last year. And I also called and spoke to a number of programs around the world that didn't necessarily have published data, but are doing tube weaning programs regularly, and just tried to find out more about them. So the wean time varies from program to program. Some programs do it very, very quickly, and some programs take a slower approach. Most of the programs have an 80 to 90% success rate with minimal weight loss, so less than 10% in the short term, no impact to growth long term. There are a variety of inpatient programs, outpatient programs, or virtual programs, and the follow-up intervals vary. So it really is a mixed bag in terms of what's out there already. Oh, sorry. So I think at this point, there isn't a best way to tube wean somebody. We just know that there are different ways to tube wean people. And so that may change 5 and 10 years. We may have more research. We might be like, oh, this is best practice when it comes to tube weaning. But for now, there were a lot of different approaches out there. So we decided to come up with our own.
So what did we do? So we had goals. Our population, we were really looking at around 10 patients We didn't have any budget. It sounds very grand when we talk about a multidisciplinary team embarking upon this pilot study. There was no new money. This was really realigning resources that we currently had in the hospital and sort of condensing some of those appointments for our families, because as I said, some of this weaning work is already happening, just not in that standardized way. So some of our goals were really focusing on what did staffing look like and what was that need as we move forward. We wanted to complete this within 3 months.
Which we were not successful, but that was our goal.
And how many appointments did we really need? And what was the average per patient? How many were booked? How many were virtual? How many were in person? How many were phone follow-up, email, consultations as well, with families contacting? And I think one of the overarching themes of this is really to try and demedicalize feeding when we're weaning. It's fascinating for me as a clinician that we are able to medicalize baby puree, because we do, because it's part of the work that we do. But I think that was one of our overarching themes. And really then thinking about, what does it mean? What does success look like when we are tube weaning? And so obviously the ultimate goal is to fully tube wean, so to remove that tube and for the child to be completely orally fed. However, recognizing that journey can take a long time, and partial tube feeding is also a success for these families, just moving them along that journey. Our inclusion criteria, we started with children under the age of 3, but actually we needed to broaden it out to children under the age of 5 so that we could get a large enough population. They needed to be medically stable and have a safe swallow. So we'll have had a swallow assessment with a feeding therapist. Needing to be able to accept some food, so either feeding themselves or accepting being fed, and will touch and tolerate being messy. Parents also, of course, at the centre of this, needed to be ready to embark upon this journey. It requires quite a lot of appointments and a commitment, so working with families to see if that was feasible for them. And then, you know, having that relationship with families around, what does feeding look like at home, and are you able to take on these strategies and recommendations at home to progress? Exclusion. So some of these are the opposite of the inclusion. But I think the key pieces to pull out here is our parent-child relationship, so that responsive feeding approach. Are families able to live within that paradigm and work to that model? If they weren't at this time, then we needed to do some work prior to the mentoring into the program. And then children who are with autism, there isn't a lot of research around this type of approach for that population, so we excluded those children at this time for our pilot. Anyone who's medically unstable, and then NPO if you with an aversion. So if you were unable to accept anything, you know, we didn't want those dual goals of decreasing enteral intake and then having to work on oral aversion at the same time. So those children were also excluded. Our team, patient and family right at the centre. And then our feeding therapists, so occupational therapists and speech language pathologists, sharing that feeding therapist scope of practice, a registered dietitian. We have peer mentors, you'll hear more about that. And then we had social work and physician support as needed for our families. And we had a remarkable booking clerk who made all of this happen with jigging appointments around. First appointment, we would describe the program to the family. And we go through the family readiness assessment. So it's almost like a contract that we're making. You'll see that in a moment. And then we would assign a peer mentor to every family. Here's our family readiness assessment. I'll let you take a look at it, but really it's that discussion with the clinician and the family, again, around that readiness, and really kind of laying out, so there's no surprises, that what the expectations are and what those demands might be for those families. So committing to the work, being able to offer a variety of foods. Food waste will occur, and that's a significant concern for some families, of course, and so that needed to be labelled. Consistent routines for children, and then division of responsibility. So thinking about Ellen Satter's division of responsibility theory, so where parents are responsible for what the child will eat, and the child's job is to is eating, and they decide how much or even if they want to eat.
Can everyone check and make sure that they're on mute? Sorry, go ahead, Louise.
And recognizing that weight may decrease, we'll talk a little bit more about that through this tube wean and what that acceptable level looks like. And then peer mentors, understanding what that relationship might be like, that it may not happen in 4 to 8 to 12 to 16 weeks, and that sometimes the tube may need to be reinserted, and that sometimes it is a journey, and so we may not get to full tube weaning in one attempt, and we might need to do some extra work and bring them back into the program. And if anything changed, or there were any changes in the medical stability, that we would cease this program. So once we'd had all that agreed with our families, we would discuss that division of responsibility in more depth with our families, and then we'd send feeding toddlers and young children the handout to our families, and that family readiness assessment was sent out to them. It was scheduled for 8 weeks of appointments, twice a week for the first 2 weeks. So these were hybrid, some were in person, some were Zoomed, and then once a week for the remaining 6 weeks. And then we had the peer mentors supporting in those relationships as needed. Here's our ready to wean checklist. This is really a clinician tool. And so it's sort of a systematic approach to looking at where our family's at and ensuring that we've really covered all our bases and covered all the topics and all the intervention supports that those families need prior to entering into the program. We can make these available at the end if people would like them emailed out.
And then just to talk a little bit about the peer mentor, Louise, because I realized we didn't have a slide specifically about it. So a peer mentor is a trained volunteer who has had a child who weaned off of a tube feed previously. So some of them were weaned off by me or other people at the Children's, and some had done it through external programs. But they all are trained by the Children's, and then they are familiar with the program, know what we're doing, and each one will call a family and support them as needed. It's not medical support, but emotional support from a parent perspective.
So program, there was a drop in enteral feeds by 20% at the first appointment, drop of 10 to 20% at each appointment subsequently, and then dropping water flushes as the families move through the program with their children. And then typically there would be a feeding observational review at each appointment, and then an in-depth discussion around what those changes were since the previous appointment, and having those discussions, and RDs can talk more to that about the sort of output. What's happening for these children, really thinking about constipation and hydration. They were weighed weekly, and with that expectation of up to 10% of a weight loss, and then parents were looking for constipation and signs of dehydration. I think really sitting in that moment there, understanding that for these families, we are asking a huge amount of them. We're asking them to all the medicalization that they've had ever around their feeding, which may well have started early in a NICU, for example. We've asked them to measure and weigh and control and time and do all of these pieces around their feeds. And we're asking them to let go of that and to trust the process, which is a huge ask.
So the results so far, we have 9 patients that have gone through so far. Number 10 just started. 7 patients are off the tube completely. 1 is still in progress. He started a bit later. And 1 unfortunately got C. diff and had to go back on tube feeds because just was not able to keep up. The average weight loss was 3.5%. But it really varied. Some patients gained weight the entire time that we were weaning, and others lost the full 10% and then started gaining after that. So you can see if we look at their intake from food at the start of the wean, it really varied. So 3 patients took nothing by mouth. They weren't orally aversive. in the sense that they, wouldn't put things in their mouth, and they wouldn't, and they accepted being touched and would occasionally take things like vitamin D by mouth, but they were not eating or drinking anything beyond the odd sip or taste at the start. And then others had more intake, 20% up to 75% of intake from food. And the number of days it took from the start of the wean to not using the tube anymore also really varied. So Mr. 75%, we just stopped him at the first appointment. Others, 10 days up to close to 70 days. This was based on the needs of the child, but also on the needs of the parent. So some of the kids maybe could have progressed more quickly, but their parents wanted to go a little bit slower. So we just worked together every appointment, coming up with a plan that everybody feels comfortable with. So parents don't track fluid intake or any intake. We're not asking them to write down every bite of food or every sip of fluid, partly because we are working on demedicalizing, and we want them to just look at their child and be looking for signs of hunger and fullness. Are they peeing? Are they pooping? All of those kinds of things. So they do watch the urine output, and they look for signs of dehydration. All the patients did start drinking water along with other beverages as the wean progressed. We didn't replace any feeds with water. Constipation was fairly common at the beginning, but quite mild, and most patients were already on Restorelax when the wean started. So we often just had to increase the dose a little bit, or one family gave prune juice, the child drank prune juice, that seemed to do the trick. And for the kids who had reflux symptoms and frequent vomiting, this stopped almost immediately. As soon as we did the first cut of the tube feed by 20%, the reflux symptoms and vomiting stopped. About half of the patients still need feeding therapy after the wean is complete to work on texture progression. And we still need long-term growth data. The first patient has only been off of the tube feed for 4 months, so I don't know what that's going to look like.
So we are going to discuss some themes, and this is going to be where we move out into our breakout groups. The first group that we're going to, you will each move through, and the facilitators, no, you will stay where you are and we move into your groups. You will each take part in each of these. So this first one I'm going to be facilitating. So this is feeding therapy side of things, and these are some of the key themes that we're going to talk about. Our next group is dietitian. And Sarah will be facilitating that piece. So lots of interesting discussion there. And then our last one is our parent perspective with Pam. Thank you very much for being with us, and really looking at what does that mean for our families. And I think the key one for me that really resonates is what happens when your child is not a tube-fed child anymore.
And Pam was one of the parent advisors who worked on the pilot project with us, and then she became a peer mentor as well during the wean.
I can just see that there's a couple of questions at this point. I wonder, before we jump out into our groups, did they need an instrumental to confirm safe swallow? Hi, Shania. No, not necessarily. They may have had one along their journey, and recognizing that these children are at various points in potentially a long feeding journey of tube feeding, so not necessarily. And is family readiness assessment a formal tool, Sarah?
Define formal, like validated? No. Written down on a piece of paper? Yes, Melissa.
It came from the lit review, really, from looking at other sites, and developing a tool that was going to work. It was sort of built by consensus through our eating, feeding, swallowing team. Was age 5 in or out of the inclusion criteria?
It never came up, Sharon, because we didn't have any 5-year-olds sent to us. So I didn't have to make any decisions. I was very flexible. At one point was recruiting. So
under 5 was included, over 5 was excluded. So I wasn't sure about the 5-year-olds. Okay.
Our oldest one was 4 and our youngest one was 11 months.
Great. Okay, so by some sort of magic that I'm not responsible for, we will be moved into rooms. So see you shortly.
Hi, Louise. I'm just clarifying. It's Crystal. Group one, room one is going to start off with the RDs. Room two, feeding therapist, and room three is peer mentors. And just so everyone knows, I'm going to let you self-select your room. But once you get in there, do not leave your room, because the facilitators are going to circulate throughout the rooms. So you are going to get to hear all three, get to have discussions on all three topics. And facilitators, I'm just going to pop a reminder in your chat when you're in your room that you have 1 minute left to come out and go to the next room. So number one, facilitators, you're going to go to two, two to three, and three to room one.
Thank you for organizing us, Crystal.
You're very welcome. Let's just hope this works. So I'm going to pause recording.
Who's talking about this, Louise? Me or you?
You're going. You're going to do it.
All right.
I'm just here for the ride now.
Yeah, so just a bit of a wrap up. I was saying we need more time. That's my learning from today. We didn't have enough time in the breakout rooms to really get into stuff with people. But would love to hear from other people around their experience. I had some great people were sharing some of their experience in the breakout room, which is fantastic. Thinking about long-term supports that need to be in place for these kinds of things, from staffing and logistical rooms, all those things. And then what comes next. So we have a wrap-up meeting for the pilot program in 3 weeks, I think, just to talk about the results from the 9 that will be done, not from number 10 who's joining in late, although maybe she'll be super quick and we'll see. And kind of figuring out, like, looking at some of those pieces around how many appointments did families need, how long did it take, did we feel like one of the learnings from one of our patients, it took a little longer to stop using the tube, so then they pretty much stopped using it and went back to their original feeding team, and it felt a bit abrupt, so that we were like, oh, maybe we need to have a bit more time between that we stop using the tube, maybe we do a couple of appointments and then transfer them back, so we just have a bit more of we're weaning each other off of the tube weaning program. Does anyone have any programs, like tube weaning programs, that they have started in their area that they're thinking of starting?
Well, actually, one of the questions that's come up from Kerry is, will you be sharing this protocol province-wide?
Oh yeah, I was wondering where to do that. Maybe on the SharePoint.
I'm very happy to share this information. But yeah, I think that's an excellent question. What else is happening provincially? Because, and you know, we're all kind of on that continuum of supporting children, maybe post tube wean, that's happened, you know, not part of this pilot, but through everybody's general work. Does anyone have any comments or questions or experiences there to share?
Well, maybe I'll just add, like, I think before it becomes a province-wide, like if we're talking about protocol, I think we need to come to a consensus across the province before it becomes a protocol that we would necessarily post. So I think our intention and purpose behind the pilot was to explore and see whether or not the proposed steps that Sarah and Louise have explained, whether or not we want to continue, like whether or not those were effective, whether or not we need to do another PDSA cycle to explore any bits or pieces that maybe didn't go as well, although we're generally speaking, I don't know what those would be. You guys could speak to those. So I think it's a great question, Carrie, but I don't know if we're ready to do that quite yet. So our wrap up will be really important, and just talking about next steps and whether or not we're doing another PDSA cycle or whether we're bringing this up to the leadership groups within PES, like our new sustainability structure, and kind of decide what those next steps are as far as scoping it more broadly. And Melissa, sorry, go ahead.
I was going to say, just I 100% in agreement. And I think from our sharing what we've done so far, sharing the resources, we could put that on our PES COP page, recognizing that this is one team's experience of a short-term 3-month pilot. But yeah, absolutely, this is a an excellent place. Yes, thank Crystal. I think that's probably the natural place for this.
I could also share the list of resources, like studies and things that I looked at, and then people don't have to reinvent the wheel trying to find all the studies. I can just make a list and people can take a look at some of those things too.
Other questions that have come up here. Do you ever run in? So Melanie has asked, do you ever run across any trouble weaning tube feeds for kids with fundo who still need it for venting at times?
I have not seen that. Anybody else?
Any of our nurses or GI physicians are able to respond to that? We will add that. Another question is, we serve Indigenous populations and new Canadian families. Does anyone have any experience with culturally diverse practices? Don't know if from our population here, did we have any new Canadian families?
Yeah, we had a family that we used interpretive services, like the video interpreter for.
Were there any key findings from that, or thoughts or themes that came out of that specific child's journey?
I mean, I only talked to programs across the world that spoke English because my other languages are not strong enough to do this kind of work. So I don't have like that kind of experience where I've spoken to programs in other parts of the world. I mean, we're patient-centered, right? This is a team approach. We're working with families. So we're not dictating how this goes, just making suggestions, having conversations, doing what works for them.
I think it's important to say that this wasn't a formal research study. This was actually us just aligning our practice that was already happening on site with a slightly deeper dive into some of this kind of the updated literature that's around about it. So it was never meant to be a formal standardized study in its approach. So Rochelle has asked, I think there are many RDs in the province who've worked with children off of tube feeds with less formality and no protocol. I'm wondering if you can speak to whether the allied health workload per patient was significantly greater during the wean period. Will workload limits be a barrier to weaning feeds? Great question. So I think when we look at workload, like we said, we sort of just realigned. So these children would have been seen for probably more appointments if we'd done it over a long period of time without that standardized approach. Catherine's nodding her head. Catherine is,
yes.
Frontline. I don't know if you want to speak to that from your workload.
I can only speak to a couple of the patients that, and this is a question that's, come up a lot, but I think in the short term, one of our kiddos had been on a tube for quite a while. And, this speaks also probably to readiness in terms of when the child is ready for this. But I'm thinking of one in particular where if we had done a more aggressive, I guess, approach earlier on in his time, I think the service that resources that he had used up over his short life would have been significantly reduced. So I think it's a patient by patient kind of thing. I think there's some readiness questions as to whether or not a child's ready for that. We can't really measure that, but I think that with the inclusion criteria that we have and determining who's best suited for this type of program, I think in the end, it's a good use of resources, because I think this process could be drawn out much further and using a lot more resources if done differently. But of course, there's many, many ways to do tube weans. I mean, many people are doing it currently on their own or with other people. And so we know, and that's part of this discussion, really. This was one way to do it. But I know for some of the patients, that was really what was going through my mind was, wow, because some of them were eating, feeding, and swallowing patients prior to. And so, yeah, I think of a couple in particular where we were like, wow, this could have been, he could have used a lot less resources in the end.
That kind of ties in a little bit to this. Melissa's asked a great question. So we're promoting this. We talked about a kind of more aggressive approach to it, which I know you don't mean aggressive, but you know, a more assertive approach to it, or timely. Melissa has asked, we promote a child-led approach in the PCPG. How do we balance that with the weaning % decrease of enteral feeds? How do we balance that?
One could argue that this is more child-led because we are actually removing that imposed tube schedule. We are actually trying to learn the child's cues and learn, you know, have them develop those things rather than an artificially imposed volume and timing based schedule. So I think they marry quite well. And of course, as Stan said, you know, we might do 20% off the start, but we're evaluating all the way through. And we were like, okay, maybe we need to dial it back. Maybe we need 2 weeks before we cut another feed. Like, it is not super structured in that sense, because then we'd be going back to a very medicalized way of doing things, right?
And
so
I think it kind of answers Diane's question too about the drinking. If you have a client that just doesn't drink enough, like we follow a responsive feeding approach as well. And, you know, we would work on, if you've got a kiddo who isn't so keen on drinking, like bring in different vessels, try to make it fun, different straws. Can you drink from, you know, even a spoon? But if the child isn't, you know, only taking a few sips and clearly that's not enough to maintain hydration, then yeah, we'll still need to use that tube for hydration. And that child may just need a little bit longer until they get to the point where they're drinking enough orally that we can further cut the tube, right? Or we introduce lots of, like Catherine is saying, ice cream, cream, you know, whether it's, maybe they'll take smoothies, maybe they'll take freezies, popsicles, soups, whatever, like any other type of liquid. But 100%, if they're still not taking the amount that they need to sustain that hydration, then the remainder would have to be offered by tube still.
But I think that's the key point. It's the amount that they need to sustain hydration. It is not us deciding how much liquid they need to take in a 24-hour period. So we are going slow with the wean to give them those opportunities to learn to drink more. But we don't have an amount that we tell them they have to get their child to drink. We're like, are they hydrated? Are they pooping? Do they seem happy? All of those things. Because a lot of families come in thinking, well, they have to drink. Just today, Catherine and I had this 1,200 mils. And I was like, no, he doesn't necessarily have to drink 1,200 mils, because he eats soup and he drinks other things, like he eats other things that have water in them. And, you know, we have to look at the whole child. It can't just be numbers.
And, you know, I'm thinking of one too, Sarah, where we saw where, you know, the child came in and they didn't look good. You know, like her color was off. She was lethargic. She looked not great. And we're like, you know what? We might need to, you know, we might need to reintroduce a feed here. And even the timing of when that feeding was offered, you know, we manipulated. Yeah, it was the same amount, but the time of day that it was offered made a huge difference for that little one. So they were all very unique in their own way, right? So as much as we're saying this is a protocol, there were some, it was more, no, we're not, or it's been referenced as a protocol. It's more of a guideline, you know? And so I think we, you know, all practice from a responsive feeding kind of lens. And I think also we needed to adjust in each case for sure.
Yeah, and I'd mentioned in one of the breakout rooms, Sarah, the client that you and I had, where he got sick, and then for a little while, like you had discussed with mom, then we implemented the overnight feed again because he just wasn't interested in taking enough orally while he wasn't feeling well. So we definitely, yeah, we had to adjust a few times.
Following on from that, so Melissa has asked, were there any go-to tools that were used for teaching hydration to parents that weren't volume-based?
Yes, there's a very nice website, pedialyte.ca, that has a beautiful little diagram around what are the signs of dehydration in babies and kids. And so I just took the diagram and shared it with them. And we asked every appointment about hydration. Like, we joke that they get tired of us asking the same questions over and over again, but we're asking, well, first of all, we're seeing them every appointment. So we're looking at them, doing physical, not like a physical exam, but looking at them. But yeah, using that, I just used that diagram, and I wish I could draw, because then I could just make a really cute one that I wouldn't have to steal from pedialyte.ca.
Now, Rosalind has asked, Rosalind, was there a time frame for the criteria of the 10% weight loss as a marker to stop the trial? Or was it just once they'd lost 10%, you would stop the wean?
If they lost more than 10%, then we would probably stop the wean. It just happened the one time, and he was already weaned, but then we restarted the feeds. He was the patient that Steph and I shared. We had a couple others that hit the 10% mark, and I just really hoped that the next time they came, they would weigh more, and they did. So that worked out nicely. But also they were progressing. They were eating more. They were drinking more. They were happy. They had lots of energy. They were running and playing and singing and dancing and doing all the things that they needed to do. The patient that Catherine was referring, when we decided to change when we gave the feeds and we didn't reduce that week, she didn't seem happy. She wasn't full of energy. She wasn't, and she hadn't even lost 10%. Like, so it's not just weight loss. It's like the child, and are they showing signs that they're feeling good and doing all the right things, or are they not? So, but I did sometimes fret about it at night, that they weren't gonna gain weight. So far, everyone has, except for that one.
And Sarah too, I think in between our scheduled sessions, sometimes you'd be connecting with parents as well.
Yeah, sometimes they'd call or send me emails, or we were available if they needed to talk.
It's also very interesting, the whole parental anxiety piece, because there were certainly parents who were all in, couldn't wait for this to happen, were really excited, continued to have that feeling all the way through. And then we had a lot of people who were very apprehensive. And, if we hit a road bump and they got sick and we'd been off the tube for a couple of weeks, oh, I want to put it back in. It's like, nope, that's not an option anymore. So, that's where we were talking about that cushion of a few transitional appointments once the tube has been removed, to help them through that period of time, because for all this
Also,
time
we'd like a social worker and psychologist.
Yeah, right. They've had that insurance policy when their kids have gotten sick, and that had to be explained that that's not an option anymore, right? So that was quite an interesting process too.
We have Pam on the line, who is our peer mentor, parent advisor. Pam, I don't know if you have any comments about any of these questions that have come up from your perspective. Put you on the spot. Apologies.
Oh, that's okay. I think I spoke to it in most of the rooms too, but I would agree with the anxiety piece. And I think that too is where having the peer mentors can be very valuable, to just to say, yeah, I get that, and I get the anxiety that comes along. And then also having the peer mentor involved once the tube comes out, because it is that loss of control that you've had over them. So being able to even, share strategies that maybe worked once your child was weaned from the tube, what worked for me, that they might be willing to try and bounce ideas off to, and just say, hey, yeah, I see you, I get it. So
we couldn't have done it without the peer mentors. It really did make a big difference. You could see a drop in the stress level once they'd spoken to their peer mentor.
So I don't know if you can see the questions. How many started the pilot with an NG versus G tube?
Oh, good question. I think we only had 2 NGs and the rest were G tubes.
And how long had they had their tubes for?
Well, the youngest patient was 11 months and he had it, I think, pretty much from the get-go.
Yeah.
And then the others were in the 2 to 4 range and they had it for most of their lives.
And then a question Alison asked was this for all children with NGs? If they had a PEG, did you remove the tube at the start of the tube wean, or when the PEG NG, when was the tube removed?
The NGs are removed when the family feels ready, like once we've cut the feeds to a certain amount and they feel ready to take the tube out. The G tubes are all still in place, like that's not our decision to make.
Any other questions or comments or thoughts? Otherwise, thank you very much to everybody.
Sorry, Louise,
yeah.
I think there was one
Oh.
question from Sarah. Was the 20% reduction in feeds a small amount from each feed or a single feed? Or was that a discussion between you and the family? And yeah, it was a discussion between us and the family. So sometimes we would talk about what the day looked like and which ones would be, you know, the most convenient to remove versus taking a percentage off of each one.
Like often the pukers puked the most in the morning. So we would be like, let's stop that one first. But for sure, it was a discussion every time. What do you want to do?
Yeah. Mary Ellen asked, what's next? We'll have the review meeting. And then we need to look at the metrics as well of that kind of staffing piece and how long patients waited, and also for our clerical staff who worked wonders to kind of bring all of these people together.
Yeah, and then I've asked all the families if I can get a wait 6 months from the time that we took the tube out or stopped using the tube, just to get more data on, okay, 6 months later, what does their growth curve look like? Well, weight and height if possible. And they've all agreed that that's fine. And I'm just to connect with them when that happens. And then we might write a paper. We don't know. We'll see. We'll see how much time we have.
Any last questions before we wrap up?
I just, Mary Ellen here, just in the sense of about what next. Can we refer more children? Is there opportunities? Because of course I'm thinking of it from the school lens. We have a lot of children that are receiving supports for water feeds. And again, I just, in the sense of, would love to know if that's something that we could refer to refer to this program.
Maybe not yet. Maybe connect with us in a few weeks once we've finished gathering all our data. Does that seem reasonable? And the water thing, like, I have not weaned anybody just for water. I know lots of people have. So that might be a different PDSA cycle.
Yeah, I was just going to say that, Sarah. I mean, again, given it's a pilot, we still have to decide whether this is going to be an ongoing program, and if we need to do any further PDSA cycles or what other data we might like to gather. Because I think we didn't quite answer one of Melissa's questions around, did we do a pre and post for, you know, I think it was something around variety of food intake or types of foods or things like that.
I mean, we have all that information for sure.
Okay. Yeah, and then the sustainability piece too, around, like, people have been asking about the resources that go into it. Can we sustain it? What does it look like to continue the program with our current staffing? So we've got a lot of kind of regrouping and decision making before next steps, but I think on the overall, it certainly sounds like it has gone quite successfully. So that's really cool. Really appreciate all the sharing today. I've learned quite a bit as well. Thanks.
Melissa asked a great question, which, have we identified the barriers to weaning across Alberta? The Children's Hospital can't answer that, but everyone on this call, if I think you know, that's great food for thought, and it'd be really interesting to hear what is happening at other sites. Maybe that's an ongoing discussion on our online community of practice as well, because we can certainly have those debates and conversations and discussions and sharing of information on that forum as well.
One thing to add on that is, I think, Sarah, did you have and Steph, you had a kid from Lethbridge, is that right?
Yeah.
So we did do this with a couple of patients where they didn't actually come in to our site.
Faye is Faye here still? Faye was his dietitian in Lethbridge, so it was
yeah,
teamwork.
Yeah, so that's another, you know, possibility, right, in terms of collaboration across the province.
Hey, wonderful. Well, thank you, everybody. Thank you to the team. Thank you to everyone who's contributed today. And we look forward to seeing you at our next community of practice in the coming months. And I'm saying that suitably vaguely because I cannot remember the date and I apologize. Crystal, I don't know if you're able